Okay, Chapter 49, Neuromuscular or Muscular Dysfunction in Pediatric Patients. First, we're going to cover cerebral palsy. It's a group of permanent disorders of the development of movement and postures causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. It's characterized by abnormal muscle tone and coordination. Incidence, about 2.4 to every 3.6 per 1,000 live births. Most common permanent physical disability in childhood. 15 to 60% of children that are affected may also have epilepsy. There are prenatal brain abnormalities. There's gross abnormalities of the brain, vascular occlusion, laminar degeneration, effects of low birth weight, anoxia or hypoxic infarction or hemorrhage. It can be a cause. Types of movements are spastic, dyskinetic, ataxic, and mixed. Look at box 49-1 on page 1572 of your textbook for clinical classifications of cerebral palsy. For prognosis, it depends on the type and severity of the condition. Moderate impairment, 85% of patients can achieve ambulation. Cognitive impairments, about 30 to 50%. Growth is affected and survival is dependent on comorbid conditions. So let's review clinical manifestations. Infants at risk require careful assessment during early infancy. Neurologic examination and history are primary means of diagnosis. Other diagnostic tools include neuroimaging and metabolic and genetic testing. Clinical manifestations are delayed gross motor development, abnormal motor performance, alterations in muscle tone, abnormal postures, reflex abnormalities, and associated disabilities. Look at box 49-2 on page 1573 of your textbook. Early warning signs of cerebral palsy, you want to look at box 49-3 on page 1574 of your textbook. When you look at therapeutic management, let's look at goals of therapy. You want to establish locomotion, communication, and self-helps. You want to achieve optimal appearance and integration of motor functions. You want to correct associated defects as effectively as possible. You want to provide educational opportunities adapted to the child's capabilities, and you want to promote socialization. Therapeutic management can also include ankle-foot braces can be worn, orthopedic surgery to correct spastic deformities, pharmacologic agents to treat pain related to spasms and seizures, botulinum toxin A injections, dental hygiene, and physical and occupational therapy. So, care management. Nursing care includes assisting the family in devising and modifying equipment and activities, medication administration, safety precautions, recreational activities, physical, speech, and occupational therapy. You want to provide support for the family and the patient. Look at nursing care plans on pages 1576 to 1577 of your textbook. Okay, let's cover neural tube defects. It's the largest group of congenital anomalies. Normally, the spinal cord and the cauda are encased in a protective sheath of bone and meninges. It is a failure of the neural tube closure, produces defects of varying degrees. Incidence is usually about 0.3 per 1,000 births. Occurs more often in Caucasian and Hispanic children. Prenatal detection, they may have an elevated alpha-fetoprotein level in amniotic fluid. There's also the uterine ultrasonography at 16 to 18 weeks of gestation. Or we have the chorionic villus sampling, but not done before 10 weeks of gestation. Women of childbearing age should supplement folic acid with 0.4 milligrams a day. If there's a history of neural tube defects, they should supplement with 4 milligrams a day. Then we have the cereal grains fortified with folic acid as required by the U.S. Food and Drug Administration in 1998 in an effort to minimize incidence of neural tube defects. Supplementation should begin before conception, and it prevents about 50 to 70% of all cases. Pathophysiology of the neural tube defects. There is a failure of the neural tube to close during the embryo's early development, approximately 3 to 4 weeks after conception. It could be multifactorial causes, and it could just be a genetic mutation. Some additional factors to consider are maternal obesity, maternal diabetes mellitus, and low vitamin B12 level. Okay, so some of the types, you're going to look at box 49-4 on page 1579 of your textbook. There's anencephaly, myelodysplasia, spina bifida occulta, spina bifida cystica, meningocele, and myelomengocele. Let's look at some therapeutic management: postnatal care, orthopedic considerations, management of genital urinary function, latex allergy, bowel control, prognosis. Need orthopedic consult due to developmental dysplasia of the hip and clubfoot, and can have neurogenic bladder and not empty all the way, or have issues with bowel not functioning properly. Okay, spina bifida. It's a malformation of the spinal cord and spinal canal. There are one or more defective vertebrae that allow the spinal cord contents to protrude. The higher the defect, the greater change of neurologic dysfunction. Can occur anywhere, but most common at the lumbar or sacral portion of the spine. So for causes, you had the failure of the neural tube to close during the embryo's early development, approximately 3 to 4 weeks after conception. Could be because of an excessive alcohol consumed by the mom, or inadequate folic acid intake, or even medications such as valproic acid, carbamazepine, seizures that is taken for seizures, maternal obesity, or it could even be genetic. And then we have meningocele. It contains only meninges and spinal fluid. And then we have myelomengocele. It also contains nerves. So look at the clinical manifestations in box 49-5 on page 1581 of your textbook. Okay, so let's look at some pre-op nursing care. Surgery occurs by 24 to 72 hours after birth. If there is CSF leakage, you need closure within 24 hours. You want to place the infant in prone position with knees slightly flexed. Cover the sac with a sterile saline dressing. Maintain integrity of the sac and monitor for CSF leakage. Assess bowel and bladder function. 73% of children with spina bifida have a latex allergy that can cause anaphylaxis, so always use latex precautions. Post-op nursing care. Monitor for wound healing. Watch for CSF leakage. Monitor for signs of infections such as temperature instability. See Nursing Alert on page 1583 of your textbook. You want to monitor for signs of hydrocephalus or increased intracranial pressure. May have a shunt placed. Place in prone or side-lying position. Feed side-lying position. Measure the head circumference daily. Monitor intake and output. You want to monitor voiding function and bowel movements. Avoid latex products. Look at box 49-6 on page 1584 of your textbook for guidelines, and then also look at page 1585. You may reverse the diaper. Avoid taking rectal temps. This is a costly defect because of the care it requires even post-op. So parents need some financial resources. Parents may need to learn how to cath the child to help them void. They may need suppositories to prevent constipation. You want to promote mobility with braces, walkers, crutches, canes, or wheelchairs, and custom car seats. You want to teach parents to inspect the skin daily for signs of breakdown on pressure points as well as areas underneath the assistive devices, and you want to encourage children to do as much self-care as possible. So let's look at some associated problems. Hydrocephalus occurs in about 90%. They may have a neurogenic bladder, constipation, poor anal sphincter tone, congenital dislocated hips, club feet, scoliosis, loss of motor sensory function below the defect. Let's talk about Duchenne muscular dystrophy, also called pseudohypertrophic muscular dystrophy. Most severe, most common in muscular dystrophies in childhood. It's an X-linked inheritance pattern. About 1/3 of the cases result from fresh mutations. Look at box 49-8 on page 1588. Incident is about 1 per 3,600 male births. Onset between ages 3 and 7 years. It's a progressive muscle weakness, wasting, and contractures. There is hypertrophic calf muscles in most patients. There's a progressive generalized weakness in adolescence and can result in death from respiratory or cardiac failure. Diagnosis is prenatal diagnosis as early as 12 weeks of gestation. It's established primarily by blood polymerase chain reaction for dystrophic chain mutation, confirmation by electromyelography, muscle biopsy, and serum enzyme measurement, positive family history, and display of the usual characteristics of the disease is how it's diagnosed. So some of the clinical manifestations include waddling gait, frequent falls, Gower sign, lordosis, enlarged muscles, especially in the thighs and upper arms, profound muscular atrophy in later stages, mild to moderate mental impairment, obesity. Look at box 49-9 on page 1588 of your textbook. So for therapeutic management, there is no effective treatment established. Primary goal is to maintain function in unaffected muscles as long as possible. Keep the child as active as possible. Make sure to do range of motion exercises, bracing, performance of activities of daily living, and then maybe some surgical release of contractures may be needed. We may need genetic counseling for families. It takes a multidisciplinary team to help the child and the family cope with chronic, progressive, debilitating disease. So for nursing care, design a program to foster independence and activity as long as possible. Teach the child self-help skills. Provide appropriate healthcare assistance as child's needs intensify, such as home health, skilled nursing facility, or even respite care for the family. This completes Chapter 49.